Good evening, everyone. Today we will be discussing how to approach a station or Nekoski station in general that's pertaining to suicide attempt. Remember, in suicide attempt, if it is, uh, the station says they may have suspected overdose or suspected toxicity of a medicine, and it doesn't say that they are stable or doesn't have stable vitals at the time, so it means that you're dealing with the emergency. That would be different. Here we would be talking about how to take history of and make sure the patient is safe once they have been stabilized from the initial attempt. First step, as always, would be introducing yourself to the patient since they have been stabilized right now. Hi, I'm Dr. Fayaz, one of the emergency physicians or one of the physicians on call today. I will be your provider today. May I confirm your name and age, please? So patient would state their name and age or their date of birth. Then thank you to the patient. For example, here we're using the name Angelina. Thank you, Angelina. I understand you were brought in after taking some pills. I'm here to support you. Is it okay if I ask a few questions to better understand what happened? This way we are showing that we understand the patient, we are supportive of them, and we are asking for permission to talk to them about their condition or what happened, what ensued. Now, remember, in suicide attempts, make sure you are asking about the events. Um, Use a broad question like an open-ended question such as, can you tell me what happened earlier today? Or do you mind walking me through what happened or what conspired or what happened earlier today or what happened at the time or what was going on at the time? Patient would likely answer with what happened. I took pills, I tried to kill myself, something like that. Now, next question would be, how many tablets did you take? Or uh, how much of the toxin or the medicine or the poison that they tried to take, and how long has it been? This gives us an idea of our next step. Even though they're stable right now, some medications or poisons or toxins, they can have effects a few hours later than initial stabilization. So we want to make sure we are not missing anything. Once that's done, ask about how did they take the medicine. Did they use alcohol to take the medicine, or did they use anything else? Right now, once that's done, ask about symptoms at the time. Here we are dealing with a case of aspirin overdose, so ask about some symptoms you may expect with someone who has aspirin or salicylate toxicity: nausea, dizziness, vomiting, ringing or tinnitus in the ear, or have trouble breathing. So depending on what medicine they took, or if it is noun, you would ask about the symptoms related to that medicine. Once this is done, move on to the sad person screening. So sad person, S stands for sex or gender, male or female. Females attempt more suicides in general. Men have a higher percentage of completed suicides. Um, Sex, age, this will be known from the history. Now, D stands here for depression. Ask the patient, did they want to commit them suicide? Did they took it because they wanted to not live anymore? Was it an attempt to kill themselves or end their life? Once you ask that, done, ask them about depression. Do you feel or have you been feeling depressed lately or in the past few weeks? Yes or no? Once that's done, this is your D. D is done. Now come to P. P is previous attempts. Have you ever attempted suicide before? Yes or no? You can also ask, if they say no, you can also ask if they have had thoughts of committing something similar in the past or committing suicide in the past. They will say yes or no. Now, next question would be E. Um, Next, we will screen them for alcohol use. Do you drink alcohol? Yes or no? How much do you drink? Done. After that, ask about drugs. So E would be ethanol plus drugs. Ask about alcohol, how much? Drugs, how much? You can add smoking in, but smoking is not very relevant compared to suicide. Now ask about R or rationality or rational thinking. See if they have any delusions or hallucinations or voices, they're hearing any voices telling them to do it. And ask them, do you hear voices, see things, or feel like you're losing touch with reality? This will give us an idea if patient is experiencing psychotic symptoms. Also ask them about what they did. Do they think that they have insight into it, or do they think it was a rational thing to do? Once you have done that, you move on to S again, which is suicide in family. Do you have any family members who committed suicide? Any first degree relatives, your uncle, parents, uncles, anyone in your family who has committed suicide? Yes, it raises their risk further. No, okay, that's a negative. So move on to O. Now, O is for organized plan. Did you have the did you plan it this way to take the medicine or a specific amount of medicine to kill yourself? Or was it just an impulse that you felt overwhelmed and took the medicine? Now you won't word it that way, but you would ask about specific plan. Did you have a specific plan to take the pills? Or when you took the pills, patient would say yes or no. Now, N would stand for no support, no spouse, no partner, no sibling, etc. So ask about living situation. Do you live alone? If they live alone, it's a red flag. That means they're alone. Living alone makes it easier for someone to act on these impulses or these thoughts. Ask about support. Do you have family who supports you? Do you have friends who support you? Do you have a partner who supports you? Do you have a spouse? Or once that's done, move on to the last S, which is serious illnesses. Do you have any health conditions that may make you feel like okay? So once that's done, ask about serious conditions. You can ask about heart disease, diabetes, specifically things that limit person's functionality like disability, or those are our concerns or chronic conditions that are hard to diagnose and hard to manage, especially those that have chronic pain. Ask about them. You can specifically ask about the conditions, or you can just ask them if they have any serious medical condition or illness. They will say yes or no. Once you're done with that, now how do we score sad persons? So each of these questions, they get 0 or 1. Sad persons, S is for sex. Female sex is 0 points because females in general attempt more, but they usually do not really have an organized plan, and they use means of suicide that are lethal if left alone for a long time. Men, they usually use methods that are uh, highly lethal and usually cause instant death, such as shooting themselves in the head or using a firearm. So if someone attempts a suicide and they are female, it's 0 because reattempts are also less common in women, but uh, they are still there. And age, if someone is less than 24, it's 1 point. If someone is very old, again, it would be 1 point. Now, depression, are they depressed? It would be 1 point. Previous attempt, yes, 1 point. No, 0. Use of alcohol, yes. Excess alcohol or drinking alcohol to fall asleep or deal with stress, that would be 1. Yeah, I just drink a beer so once a week or with friends, that's 0. So rational thinking, are they having any delusions or any hallucinations? 1. No, 0. Suicide in family, positive, 1. Negative, 0. Organized plan, or they planned it, like for example in this case the patient says that yes, I waited till my roommate left and then I took the pills so that I can die or I would end my life. This means that she planned it. She had an organized plan. This is one. No support or no friends or no family support or no spouse, etc. That's also one. So if patient doesn't have serious illness, zero. If has serious illness, one. Now, how do we interpret this data? If patient is 0 to 4 points or gets up to 4 points out of these questions, we say it's low risk. Some texts mention 0 to 2 points is very low risk, 3 to 4 is low risk, and then 5 to 6 it is moderate risk. We would consider closer observation and plain safety and monitor them over time, and also consider sending them to a psychiatrist. Scores of 7 or higher, it's high risk. If they still have intent, or they had an organized plan and they have access to firearms or means of committing suicide, in those cases we can consider involuntary admission. If someone had this one impulse type action of committing or trying to commit suicide, but they're not actively suicidal, we can consider hospitalization, but it's not very often that we would hospitalize such patients. We would just monitor them for a few hours and then we can send them home and follow them up through community sources. All right, now once we have done the sad persons, then we will ask them about social and functional history. Are they studying? Are they working? Are they at a job? Yes, no. Sometimes if someone um, is out of work because they got terminated or they got fired or they were let go because of budgeting issues, this can increase their risk of getting depressed and feeling like they are worthless or useless, and they may commit suicide. So we want to make sure we are covering that too. Cover safety. Do you feel safe right now? For example, if it's a female whose partner is abusive or whose partner is hitting them, ask them if they feel safe at home right now. If not, then you can manage safety planning with them. Ask them about how they are feeling. Do they still have the feeling of hurting themselves, or do they not? If they say yes, involuntary admission. If no, monitor for a few hours and then follow up in community. Finally, thank the patient. Do your closing remarks or statement. For example, in this case, thank you for sharing this with me, Angelina. It sounds like you have been under a lot of distress. You're safe now, and we will make sure you get both the medical and emotional care you need. A mental health professional will meet with you shortly for further support. Some key points for IMGs. Use sad persons verbally during the encounter in case you are given a situation or a station with someone who who attempted suicide. Always ask about current suicidal ideation plan, intent, and protective factors such as support of friends, family. Communicate with them compassionately and without judgment. Don't use sentences like, why do you want to kill yourself, or try to be a little passionate about I understand. You use sentences like, I understand you have been having this feeling, or I think or I understand it's hard for you or it's distressing for you. Make sure you're showing patient empathy and that they know um, that you are there to support them, not judge them. Finally, if you're in an exam, since exams usually do not require documentation, but if they do, make sure you're documenting everything correctly and following up appropriately. For real life, remember you would document each and everything that the patient says and then how it relates to their current presentation. Do not miss details, do not miss specifically details that may cause harm if we miss them. For example, current suicidal ideation or thoughts of harming themselves or sometimes harming someone else. Now, in a station like this, the examiner may ask you questions. Um, One of the most common question would be your differentials. What do you think is causing the patient's symptoms? And what are the tests you would order? Sometimes they will ask you, are you going to hospitalize this patient? Are you going to manage this patient in community or in hospital? And how would you assess suicide risk? How you're going to assess for red flags in this patient? Um, or what are the red flags in ASA overdose? In ASA, metabolic acidosis and altered mental status, this is something that concerns us because it's very hard to treat once metabolic acidosis sets in, and then we have to monitor them very closely, try to deal with the acidosis plus the overdose. All right, that's how to take history from someone who has attempted suicide recently. To uh, to recap, make sure you're using SAC persons verbally and taking notes, give the patient points based on their answers from 0 to 10, and then assess whether they're low risk, moderate risk, high risk, or very high risk. Consider hospitalization if they still have suicidal ideation, if they have an organized plan and they have access to the means, and make sure you're showing a lot of empathy and using non-judgmental and neutral tone and wording. That's how to approach a station with suicide attempt